Good day. Today we are talking about hypertension in pregnancy. Very short topic. Our reference is Tintinalli's Emergency Medicine. Hypertensive disorders are the most common medical complication of pregnancy. This can be divided into 5 categories: chronic hypertension in pregnancy, gestational hypertension, preeclampsia, HELP syndrome, and eclampsia. For chronic and gestational hypertension, the decrease in systemic vascular resistance results in a decrease in maternal blood pressure, and blood pressure reaches its nadir at 16 to 18 weeks of pregnancy. Blood pressure returns to pre-pregnancy values near the end of the second trimester. This could be due to increased blood volume in pregnancy, which peaks at the second trimester, in which there is 40% more blood volume. Chronic hypertension in pregnancy is defined as a systolic blood pressure of greater than or equal to 140 millimeters mercury, or a diastolic blood pressure of greater than or equal to 90 millimeters mercury that existed prior to pregnancy, is diagnosed before the 20th week of gestation, or persists longer than 12 weeks after delivery. Severe chronic hypertension is systolic blood pressure greater than 160 millimeters mercury, or diastolic pressure greater than 110 millimeters mercury. Women with chronic hypertension are at increased risk for placental abruption, preeclampsia, low birth weight, cesarean delivery, premature birth, and fetal demise. Gestational hypertension is hypertension present only after the 20th week of pregnancy or in the immediate postpartum period but without proteinuria. Safe treatment options for hypertensive women who are pregnant include labetalol and metildopa. All antihypertensive drugs cross the placenta. Labetalol is the first-line agent for chronic hypertension in pregnancy. The starting dose is 100 milligrams per orem twice a day, and the usual maintenance dose is 200 to 400 milligrams per orem twice a day. Metildopa, used safely in pregnancy for decades, is started at 250 milligrams every 6 hours per orem and titrated to achieve the desired blood pressure. The usual daily dose is 500 milligrams to 3 grams divided in 2 to 4 doses per day with a maximum of 3 grams per day. Long-acting nifedipine may be added if blood pressure is not controlled with metildopa or labetalol. Long-acting nifedipine is started at 30 milligrams per orem once a day and can be increased up to 120 milligrams per day slowly if needed. For acute management of hypertensive emergencies, hydralazine 5 milligrams IV or IM, labetalol 20 milligrams IV, or nifedipine 10 to 30 milligrams per orem, which is not a Food and Drug Administration approved indication in the United States for this particular drug, may be used during pregnancy. Angiotensin-converting enzyme inhibitors and angiotensin receptor blockers are contraindicated because of their teratogenic effects on the fetal scalp, lungs, and kidneys. Preeclampsia or gestational hypertension with proteinuria is characterized by hypertension before 20 weeks of gestation with either new onset proteinuria, sudden increase in proteinuria, or development of HELP syndrome. The cause of preeclampsia is unknown. The histologic hallmark lesion of preeclampsia is acute atherosis of decidual arteries. Atherosis and thrombosis are thought to lead to placental ischemia and infarctions. Poor placental perfusion is presumed to lead the formation of free radicals, to oxidative stress, and to inflammatory responses that may influence the mechanistic development of preeclampsia. Preeclampsia is associated with intrauterine growth retardation, premature labor, low birth weight, abruptio placenta, and future risk of maternal cardiovascular disease. Preeclampsia during an initial pregnancy increases the chances of recurrence in future pregnancies. Other important risk factors for preeclampsia include a maternal age older than 40 years old, hypertension, diabetes, renal disease, collagen vascular disease, and multiple gestation. Low-dose aspirin therapy can prevent preeclampsia and its complications. The diagnostic criteria for preeclampsia are as follows. For mild preeclampsia, a systolic blood pressure of greater than or equal to 140 millimeters mercury or diastolic blood pressure of greater than or equal to 90 millimeters mercury, and proteinuria greater than 0.3 grams in a 24-hour collection and greater than 20 weeks gestation, and no other systemic signs or symptoms. The criteria for severe eclampsia are a blood pressure of greater than or equal to 160 millimeters mercury systolic or greater than or equal to 110 millimeters mercury diastolic measured on 2 occasions and at least 6 hours apart with the patient at rest, and any of the following: visual disturbances or mental status disturbances, pulmonary edema or cyanosis, epigastric right upper quadrant pain, abnormal liver function studies, thrombocytopenia, oliguria, that is less than 500 milliliters of urine in 24 hours, or proteinuria of greater than or equal to 5 grams in a 24-hour collection, or greater than or equal to 3 plus on 2 random urine samples collected at least 4 hours apart, or impaired fetal growth. Laboratory evaluation is as follows. You usually do CBCs with differential counts since you may see hemoconcentration or falling hematocrit, and thrombocytopenia suggests severe disease. If creatinine is elevated, that also suggests severe disease. Same goes for alanine and aspartate aminotransferase concentrations. Elevation of lactate dehydrogenase levels suggests microangiopathic hemolysis. Protein in urine is usually 3 plus proteinuria. A 24-hour collection may be done by the obstetric service, and more than 5 grams per 24 hours suggests severe disease. A protein creatinine ratio of 0.1 to 0.3 indicates the need for 24-hour collection, and a uric acid level of greater than or equal to 5.5 milligrams per deciliter may suggest superimposed preeclampsia on chronic hypertension. The HELP syndrome, HELLP, is an important clinical variant of preeclampsia. HELP is more common in the multigravid patient than in the premigravid. Hypertension may not be present initially or at all. This fact, combined with the usual complaint of epigastric or right upper quadrant pain, makes it easy to misdiagnose HELP syndrome for other causes of abdominal pain such as gastroenteritis, cholecystitis, hepatitis, pancreatitis, or pyelonephritis. Pregnant women at greater than 20 weeks gestation or up to 7 days postpartum with abdominal pain should be evaluated for HELP syndrome. Complications of severe eclampsia, HELP syndrome, and eclampsia include disseminated intravascular coagulopathy, spontaneous hepatic and splenic hemorrhage, end organ failure, abruptio placenta, intracranial bleeding, maternal death, and fetal death. For mild eclampsia, outpatient management is an option after consultation with obstetrics as long as arrangements are made for clinical and laboratory evaluation frequently and close fetal surveillance. Headache, scintillating scotomata, or other visual changes, abdominal pain, vaginal bleeding, and decreased fetal movement require immediate re-evaluation. We treat severe preeclampsia with a blood pressure of greater than 160 millimeters mercury with antihypertensive agents such as labetalol, hydralazine, or nifedipine. The usual doses for these indications: for labetalol, it has an onset of action of 5 minutes, dosed at 20 milligrams IV, then 40 to 80 milligrams IV every 10 minutes as needed, with a maximum of 300 milligrams. IV infusion 1 to 2 milligrams per minute, titrated. Less hypotension and reflex tachycardia than hydralazine. There are higher doses of labetalol that may cause neonatal hypoglycemia, and longer use is associated with fetal growth restriction. Hydralazine is an arterial vasodilator. We give it at 5 milligrams IV or 10 milligrams IM. Repeat at 20-minute intervals. Consider other drug if there's no response at maximum of 20 milligrams or 30 milligrams IM. It has an onset of action of 20 minutes. It causes maternal hypotension and fetal distress, and you must wait for 20 minutes for response between IV doses. Nifedipine has an onset of action of 10 to 20 minutes. It is given 10 milligrams per RM and repeat in 30 minutes if necessary. Laboratory abnormalities in HELP syndrome include schistocytes on CBC and test of peripheral smear, a platelet count of less than 100,000 per microliter, and platelet count of less than 150,000 per microliter is suspicious for HELP syndrome. Liver function tests are often elevated but below levels usually seen in viral hepatitis, so they would be below 500 units per liter. Renal function tests may be normal or elevated, especially with blood urea nitrogen and creatinine levels. Coagulation profile is abnormal. Lactate dehydrogenase levels of greater than 600 units per liter is suspicious for hemolytic anemia, and a total bilirubin of greater than 1.2 milligrams per deciliter. The HELP syndrome is an important clinical variant of preeclampsia. IV magnesium sulfate may also be given for control of hypertension in HELP syndrome. We consult with obstetrics for admission or transfer to a center that manages high-risk pregnancy, especially in the presence of HELP syndrome. The only definitive resolution for preeclampsia is delivery. The initial management of HELP syndrome is similar to that of severe preeclampsia or eclampsia. IV magnesium, blood pressure control, and hospital admission for stabilization. We correct any coagulopathies, and if HELP syndrome is suspected and obstetric care is not available locally, stabilize the patient as best as possible and transfer to a tertiary care center with high-risk obstetrics facilities. The definitive treatment is delivery, especially if the patient is greater than or equal to 34 weeks of gestation. Corticosteroid administration can help delay delivery and improve fetal outcome in pregnancies less than 34 weeks of gestation. Eclampsia is the development of new onset seizures superimposed upon preeclampsia in a woman between 20 weeks of gestation and 4 weeks postpartum. Eclampsia should be suspected and treated in any pregnant woman who is at greater than 20 weeks of gestation or less than 4 weeks postpartum who develop seizures, coma, or encephalopathy. Occasionally, eclampsia can result with seizure in the absence of blood pressure elevation and proteinuria. Management of eclampsia includes treatment of seizures, treatment of hypertension, and emergent obstetric consultation to facilitate urgent delivery of the fetus. We treat seizures with magnesium sulfate, 4 to 6 grams IV in 100 milliliter aliquot given over 20 to 30 minutes, followed by an infusion of 2 grams per hour for at least 24 hours. Magnesium is renally excreted, and in women with renal insufficiency, we reduce the dose to 2 grams IV bolus and obtain a serum magnesium level before increasing the dose. The main side effects of high levels of magnesium are flushing, diaphoresis, hypothermia, hypotension, flaccid paralysis, and respiratory depression. When levels approach toxicity, patellar reflexes diminish and respiratory rate slows. We administer antihypertensives as suggested earlier. Replace coagulation factors if there is coagulopathy, and obtain emergency obstetric consultation for prompt delivery. Thank you.